Currently, there isn't really a great way to take out the suprarenal fixation. Most surgeons, I think, including myself, use a cut syringe. So you take a syringe and you cut the end off with a scalpel or a bovie. I've always been worried about cutting myself when I do that. That's always been my challenge with that. And then the edges of the syringe are pretty rough. So as you're trying to slide that up the aorta to reconstrain the stent, it can cause damage to the aorta, or it can just not slide smoothly. And the second method is to simply cut the barbs of cut the struts of the stent and leave the stent in place. And in situations of infection, I don't love that idea because if it's infected, you'd like to remove all the foreign material if possible. My challenge with the wire cutter has always been that it's thick, it's a blunt, it's a short jaws, so you can't always see where the tips of it are as you're cutting the wire. And then when you cut the wire, the edges of that wire are not smooth. And so then you're sewing in anastomosis right up against all of these sharp metal edges. And my thought, although this is somewhat theoretical, but my thought has always been those rough edges of wire could, over time, as they're pulsating against the anastomosis, just fray the proline and cause a pseudoaneurysm or, bleeding. We just needed a better way to do this. Every step of the way just felt like we were getting closer. And for me, it was just about meeting a need. And I really felt like the current methods that we have in vascular surgery to take this device out are not great. And so it was really just about meeting a need to help vascular surgeons, because honestly, taking out a stent graft's already a tough operation. The patient may or may not be the healthiest. So you really want to make sure it goes as smoothly as possible. So it felt like a fairly straightforward device could really make this operation much safer. Being able to safely remove that proximal stent is one of the key portions of the procedure in my mind. And creating injury in that visceral area of the aorta is really problematic to fix. It's not an easy area to get to. It's what I call high-priced real estate. There's a lot there that's very important. So we want to be able to do this safely and effectively, and also quickly if possible, because your proximal cross-clamp time needs to be short. And we do know that the shorter the proximal cross-clamp time, the better the patients do. And so my hope would be that if we're able to remove these grafts efficiently and safely, we can reduce our proximal cross-clamp time. I don't know that leaving rough cut edges of stent behind is ideal. And certainly cutting the syringe, although it works, it's definitely not an ideal solution. So I think we have room for improvement. Whether that will translate to improved patient care, my hope is that it would, and sort of intuitively seems like it should. But certainly having that step of the operation go more smoothly is an important piece of having a successful operation. I just remember being kind of amazed, really, at how easy the graft came out. I mean, I literally turned around and said, wow. It was pretty amazing that it just came out so easily. It made that step so smooth, whereas before that was always a challenging technical point for me. It really made it easy. Getting the XplantR placed right at that portion of the aorta that you are going to use as your proximal anastomosis. So the very infrarenal portion of the aorta, getting it there and then sort of slowly sliding it up, keeping the angle so that the proximal portion of the XplantR is in parallel with the aorta. And that's why the XplantR is curved, so that you can more ergonomically do that. Keep the proximal end of it in line with the aorta and just sort of slowly feeding it up. I simply would say that even if you're comfortable cutting the syringe or having another way of removing these, it would be a reasonable thing to try this device, because it really is an advance. Because it's so simple, it actually advances things quite a lot. It makes this step much easier. And so even if you're comfortable, because we've had 25 years of taking these things out without this device, even if you're comfortable with these other techniques, it would be reasonable to try this and see what you think, because in my opinion, it's made things much easier. So first, the limb or limbs are fed into the XplantR device, which I prefer to do by hand. And then a firm grip on the graft is maintained as the XplantR is inserted into the proximal aorta. And then the device can be removed. And as you can see, the barbs are constrained such that they can't enter the lining of the aorta as the device is removed. So as I advance the XplantR into the aorta, if I have significant resistance, indicating perhaps tissue ingrowth, I then can back the device out and leave the graft in place and re-inspect the aorta to see if there's significant tissue ingrowth. And perhaps at that point, a partial explant would have to be employed.